For most outpatient practices, revenue leakage is a slow, consistent loss of margin. Denied claims, delayed reimbursements, and administrative friction create a silent bleed. This chart shows data from Experian Health's 2025 State of Claims Survey. Over a 3-year axis, the line jumps from a 30% baseline to 41% of providers, now facing denial rates of 10% or higher. The friction in revenue cycle management is worsening. 68% of providers report that submitting a clean claim is harder today than it was just a year ago. While many blame prior authorization or eligibility issues, the data reveals that half of all revenue cycle leaders point to missing or inaccurate claim data as the leading driver of these denials. In the context of ICD-10-CM diagnosis coding, data errors mean submitting the wrong codes, working from incomplete clinical documentation, or missing the exact level of specificity a payer demands. The double-digit denial crisis represents a systemic, structural failure in how practices manage complex coding data. CMS manages the ICD-10-CM system as an evolving regulatory framework that requires annual updates. This tree map illustrates the scale of the fiscal year 2026 update that took effect on October 1. The largest section represents 487 entirely new diagnosis codes, sitting next to 38 revised descriptions and 28 deletions. Those deletions carry an immediate operational penalty. Submitting a retired code after October 1 generates an automatic, non-negotiable claim denial. Take neurology. The general code for multiple sclerosis, G35, was deleted and replaced by a series requiring exact documentation of the patient's MS phenotype and activity status. Before the October deadline, teams must absorb new rules, update health record templates, audit physician charting habits, and retrain the staff while maintaining daily claim volume. Failing to execute that transition has direct consequences. MD audit benchmark data shows a 2-fold increase in external payer audits over 2023, alongside a 26% rise in coding-related outpatient denials. Small and mid-sized practices face these financial penalties because their lean, static workflows lack the capacity to keep pace with the CMS update engine. When denials rise, most practice owners attempt to hire an experienced in-house medical biller. According to the Bureau of Labor Statistics, the median base salary for a medical record specialist is approximately $50,250 per year. Starting with a $50,250 base salary, we stack employer payroll taxes, health benefits, paid time off, continuing education, and onboarding costs. This resolves to the fully loaded cost. Maintaining a single in-house coder routinely costs $55,000 to $75,000 annually. AAPC data shows that highly certified coders, the specialists equipped to stop revenue leakage, average over $81,000 per year compared to non-certified staff. Practices pay for baseline administrative staff while remaining exposed to the financial impact of coding errors. Beyond the financial burden is the operational risk of turnover. MGMA data indicates that medical billers are experiencing significant industry disruption. Today, experienced coders are leaving traditional practice settings for higher-paying, fully remote roles with large insurers and massive health systems. When a coder leaves, the practice loses highly specific institutional knowledge regarding its unique payer mix and physician documentation patterns. Lean in-house teams rarely have the bandwidth to double-check their own work. This creates the risk of operating without a dedicated auditing infrastructure. This leads to a brutal scenario. Surviving a strict payer audit only to uncover systemic errors compounded over years by previous coders. Ultimately, an in-house team operating without enterprise-level training, daily auditing, and redundancy represents a single critical point of failure. High-performing practices solve this by moving away from the in-house employee model to a dedicated outsourcing framework. This approach differs from a shared billing service or a generalist BPO. Success requires a dedicated connection, a team that learns the exact workflow and specific clinical specialty of the practice. The Staffingly model is built on this premise, starting with a requirement for expertise. Every coder holds verifiable AAPC and AHIMA credentials, ensuring deep knowledge of CPT, ICD-10, and complex modifier rules. This diagram shows the mechanics of direct integration. External, credentialed specialists work securely inside the practice's existing EMR, whether that is Epic, Athena, eClinicalWorks, or others, operating entirely under the practice's protocols without data extraction. The entire infrastructure is secured under SOC 2 Type 2, HIPAA, and ISO 27001 standards, formalized with a business associate agreement before day one. This architecture succeeds because it replaces the isolated in-house employee with a highly credentialed system operating natively within the practice's software. Artificial intelligence is applied as an augmentation tool. Smart routing algorithms direct complex cases to the specific coder best suited for that exact clinical specialty. A layered quality control system deploys automated audits to flag potential issues before claims are submitted. Human supervisors back this up by conducting a random sample audit every day. Practice leadership receives a strict accountability mechanism, a weekly KPI dashboard tracking throughput, accuracy, turnaround time, and direct return on investment. This comparison matrix details the economics of the Staffingly model. On the left is the $55,000 to $75,000 burden of an in-house hire. On the right, Staffingly delivers enterprise-level infrastructure at a flat rate of $399 per week per seat, eliminating training overhead and benefits load. This rigorous structure maintains an error rate below 1% across a base of over 800 outpatient practices. Deployment is fast. Secure EMR access, protocol training, and total go-live operations are completed in exactly 14 days. The engagement mitigates risk by beginning with a 14-day risk-free pilot before transitioning to a flexible month-to-month contract. Reversing the silent bleed requires abandoning the in-house staffing model. Upgrading to a scalable, embedded revenue cycle infrastructure is the mathematical way to outpace the denial crisis.